Okay, I'm going to go ahead and finish up, try to finish up the visual part and then hit right into the hearing chapter. As I was saying before I finished, there's a chart 47-6 on page 988 that really have all the drug types that are involved in glaucoma therapy. Make sure that you review that chart and really pay attention to, how those drugs work, to really resolve glaucoma or help assist with it not getting worse, whatever the plan is there. And often, even with drugs, glaucoma therapy will fail and surgery has to be done. And then really, there's two different types of surgeries that can be done to improve the outflow of aqueous humor. And what that does is really kind of the pressure, the intraocular pressure, then because the outflow is improved, decreases the intraocular pressure and therefore improves the vision and the symptoms of glaucoma. Here's the items for the patient teaching plan. How do those eye drops work? So if they're on those drugs on chart 47, you need to know how to teach somebody about those, how to administer them, how do they monitor side effects, and really compliance and timely dosing, which is a big issue. If you are ever working on a unit that has these type of patients, the physicians are extremely particular about timely dosing of these eye drops, so please be aware of that for the future. Other eye disorders, these are just a list of a few different ones that can occur as well. Also, anytime there's reduced vision, these are some of the typical interventions. You want to make sure that you communicate about all the use of adaptive items that are available for patients. You also want to make sure that it's safe and have familiar settings. So you may encourage them to really go through and set up their households in a way that they really are very familiar with where things are kept, so that it's not a big issue where they could have taken the wrong medicine or, got the wrong item in reaching for something, or got into an unsafe walking situation because of things in their way. Ambulation assisted with their care. So making sure that they have methods to really safeguard their ambulation. At the same time, promoting self-care and independence for as long as really possible. And then often they may need psychosocial support for really adapting to lost sight. And there are a lot of agencies out there that do provide support for vision loss. And other teaching that does help people find different ways for dealing with that. Now I'm going to move on to chapter 48. These first few slides just really show you the anatomy of the ear, so I won't read those to you, but letting you know kind of what does the external ear look like, what's the middle and inner ear look like, and here you've got a good example of, showing from the external all the way to the inner. This third one really is just a picture of the eardrum, and so you can kind of see the surface of it and what should look normal. And then the last one here is kind of a enlarged vision of the middle ear. And I will tell you at the very end of this, I gave you a YouTube that deals with hearing aids. Please watch that, because in the beginning of it really goes through a very precise how a review of the anatomy and physiology and how the actual ear works and how hearing takes place. And I think that will kind of pull all that together for you. These are just some assessment techniques. Typical patient history, you're going to observe the patient listening as you're talking, as family members are talking in an interview situation. Watch their posture. Do they tilt their head to one side? Do they look to a family member to answer for them? How appropriate are their answers to questions? Is it that they're confused, or is it because they really can't hear you? Gender plays a role in hearing. Some diseases like osteosclerosis or otosclerosis is more common in women, whereas Meniere's disease is more common in men. Other things to kind of observe or ask the patient about is, have they been having any ear pain, any discharge present? Are they having vertigo, tinnitus, decreased hearing? Is it on one side or the other, or both? Any difficulty understanding? Have they had any past ear trauma? Do they have a history, or currently do you notice that there's cerumen buildup or wax buildup? Do they use hearing aids, and have those been helping? What medications are they taking, or any of those ototoxic drugs? Or are they in a work environment or a hobby environment that exposes them to loud sounds that could be creating problems as well? In looking at family history, you want to look at who in the family has had hearing loss. Was it one-sided, both-sided? Was it due to trauma? Was it due to genetic issues? Was it specific diseases that they can remember? Current health problems that you want to assess for are things like heart disease, hypertension, or diabetes, because we know those all decrease blood supply, and it's not any different. They can create lack of blood supply to the vestibular system in the ear as well. These are some of the basic things that you want to assess visually without, and can tell for the most part from the outside of the ear if there's an issue going on. Using an otoscope, I've given you a YouTube video here that gives you a good rundown on how to use an otoscope. You're looking for patency of the external canal. You want to look, is there any lesions or excessive wax in the canal that may be creating a blockage to hearing? Is the tympanic membrane intact, or is there inflammation associated with it when you look in there? These are some general hearing assessment ways to test the patient. A general voice test has the patient cover one ear at a time, stand 1 to 2 feet away, while you as the caregiver whisper a statement and ask them to repeat it. If you sense that they're watching and reading your lips and not really doing this from a hearing standpoint, you can cover your lips or cover your mouth so that they're not able to do that. Audioscopy and tuning fork tests are usually done by more a healthcare provider or a nurse practitioner or an audiologist. So those are not ones that we do, but just know, kind of what some of those are for. Hearing loss can be conductive, meaning that there's an obstruction of the sound wave transmission through the ear canal that is being affected, or it can be sensory neural, meaning that there's a defect in the cochlea, the 8th cranial nerve, or the brain itself. And some disorders of hearing loss can be a combination or mixed with both of these as a cause. These are just some pictures of the Weber and Rennie tests that are done with the tuning fork test. Other diagnostic assessment, lab tests, there's very few, mostly just ear cultures are an issue that you would look for. Of course, severe infections might be, you're looking at white counts as well. Imaging, they'll usually do CT with contrast and MRI. Other testing, more extreme testing, is going to be audiometry, where they really look at measuring the acuity of sensory perception of sound, and then tympanometry, which looks at the mobility of the eardrum and whether it is responding to the sound. And then several of these other things that are very specific that they kind of go down the line and test for if other things are not showing deficits. These are a lot of conditions that affect the external and the middle ear. External otitis, which is called swimmer's ear, can be allergic or infective. It occurs more in hot, humid environments. Perichondritis is an infection of the fibrous tissues surrounding the cartilage of the ear. You see this sometimes with people who've gotten ear piercings or gotten bites to the ear. Cerumen or foreign bodies may be blocking the ear canal. Cerumen can be irrigated out, and there's a very good step-by-step process for doing irrigations for that in your textbook. And foreign bodies are generally removed by a healthcare provider. Otitis media can be acute or chronic infection of the middle ear. Mastoiditis is infection of the mast air cells that lead to bone infection in the mastoid bone, and that because bone infections are often very hard to penetrate with IV antibiotics, it can progress to meningitis and even death and brain abscess. And so often infected bone may have to be surgically removed, and the tissue all around it, called a mastoidectomy or a tympanoplasty, and sometimes those two are done together. Trauma can result in eardrum perforations. Myself is a good example. I was once struck by lightning in my right ear, and it burned out 30% whole of my eardrum. Other types of trauma that are pretty common is something hitting the ear with force, like in an accident, that may cause enough pressure to actually rip the internal part of the eardrum. And then a lot of people that go out hiking will get puncture wounds, strangely enough, from limbs of trees and things that aren't really typically you wouldn't think of. Neoplasms or cancerous or some type of tumors are pretty rare, but tumors can be removed with surgery. This is just a picture of otitis media. You can see, some inflammation. It can be acute, chronic, but on the right side there's actually a perforation, so it has been problematic to the point of causing a perforation. These are conditions that affect the middle ear. I'll try to run through the rest of these as much as I can. Tinnitus is continuous ringing in the ears. You see all the causes there. Many things can cause tinnitus. Often the main way to treat tinnitus is to find the cause and treat the cause. Often if it is driving someone completely nuts and they cannot find the cause, they will treat that with just like ambient sound to kind of drown out the tinnitus, like particularly when they have to go to sleep and things. Vertigo and dizziness, this will kind of give a feel like things are spinning around or whirling in space, and it can cause people to have nausea, vomiting, falling. What they often do as interventions is teach the person to really restrict their head movement, no quick movements. They may use over-the-counter Dramamine or prescription drugs like meclizine or scopolamine. Labyrinthitis is infection from the middle ear that moves to the inner ear. They will have hearing loss, tinnitus, nystagmus that's on the affected side of the infection. This is treated with systemic antibiotics, and it can also lead to meningitis. So the patients really have to be told they have to complete all the antibiotics, even if everything's feeling much better. They've got to take them all. Meniere's disease has three main features. Know what those are. They're listed. It can be intermittent or continuous, but it really will incapacitate you for hours to days until it is relieved. It's caused by excess endolymphatic fluid, and it can cause a permanent hearing loss. There's a special diet called a hydrops diet that's in your book. Drugs are given for symptom management. They may be put on diuretics or nicotinic acid for a vasodilation effect. Acoustic neuroma is a benign tumor of cranial nerve 8 that damages other structures as it grows. It can enlarge and cause neurological problems in the brain. It's found on CT or MRI. Surgical removal is via craniotomy is the treatment of choice, and they have to be really careful to preserve the facial nerve or cranial nerve 7 when they're trying to remove this thing. and usually any remaining hearing is lost after the surgery. The good news is they rarely reoccur after surgery.